Anesthesiology, a unique and important role within the medical profession that requires intense physical and technical ability, patience as well as compassion. Now, anesthesiologists from across Europe and around the world are coming together in Vienna, Austria. With a rich history in music, art and psychology, this week the city will host the very latest findings and expertise in education and innovation across anesthesia, intensive care, pain, patient safety and perioperative medicine. With attendees coming together to save and improve the lives of patients everywhere, we're here for Euroanaesthesia 2019. This is Euroanaesthesia TV. Welcome to the Vienna Messe, our home for the next few days as the European Anesthesiology Congress gets underway. We're here to chat to some of this year's luminaries, including the European Society of Anesthesiology's President and President-elect, in an in-depth interview coming up a bit later in today's show. So, who are we? We're Euroanaesthesia TV, the official TV channel of the European Anesthesiology Congress. You can find us on TVs around the venue, in select Vienna hotels, and of course, online. We'll have a new show for you each day of the meeting, so keep watching. Now, as today's show kicks off, let's look at what's coming up.
And we are bringing together patient safety experts both from North America, United States and Canada, and from Europe, and sharing together experiences and projects regarding patient safety.
The consequence of popular must be that we improve the application and the acceptance of neuromuscular monitoring, which is a key element of safe management, and we need as a society to come up with appropriate guidelines and implement these guidelines into clinical practice. This is one of the major lessons from this study.
What we need is to have the data coming out of the machines, breathing machines, monitoring, being collected in devices where all these data can be then increased to big data and then be analyzed and telling us then what we have to change in our practice.
First, today sees the International Forum on Perioperative Safety and Quality, as physicians from around the world share expertise and guidelines in ensuring patient safety.
Today we have the joint meeting of ESA and ASA for patient safety. It's a joint meeting that is called the International Forum on Perioperative Safety and Quality. And we are bringing together patient safety experts both from North America, United States and Canada, and from Europe, and sharing together experiences and projects regarding patient safety.
During the keynote lecture, Rona Flynn mentioned the problem of time pressure, and she described this in a very impressive way. And this is what many anesthesiologists actually affects and contributes a lot, at least to our feeling, to patient safety problems.
Also sharing the experience of medication shortages that we are experiencing in North America, but also in Europe. This is an increasing problem. What was seen before just as a management problem, now it's getting into the clinics, and we are starting to have patient safety issues, not having available specific medications.
According to what the panel said, we as professionals, especially representing a number of international organizations, have probably opportunities to try to improve the situation by international collaboration. This is what one of the speakers, Adrian Gelb, suggested, to come up with a list of very necessary drugs, and to try, in a cooperation of international societies, to convince decision makers and those responsible for policies to support a minimum standard of important drugs.
We had the opportunity to have the experience from Canada brought into Europe of a transitional pain treatment unit to help deal with patients that are in chronic use of opioids into managing the acute pain after surgery.
Postoperative pain management is an area where patients are often not well monitored. They're out of the operating room, and there's huge room for improving the monitoring and the safety of patients.
Patient safety is of course an essential part of the job of the anesthesiologist. So we wanted to find out from attendees what patient safety means to them and how they maintain it.
Patient safety for me means I have a good night's sleep because my patient is safe, and there's a lot of arguments in the international community how countries and local societies could promote patient safety. As an anesthesiologist, it's safety we sell.
Patient safety means to me getting the patient from when they enter the hospital, through the procedure, through the whole hospital journey, to the end of the procedure or the end of the journey and out the front door home again with the best possible care and the highest possible standard.
Every anaesthetist, anaesthesiologist in the world wants the best outcome for their patients. We're all focused every day on patient safety, but sometimes you need drivers, support, and a global perspective and initiative to actually achieve the safest outcomes.
Patient safety means our job. Patient safety means quality, and it's our first goal for my life, for my job, and for my team in Colombia.
I'm a nurse anaesthetist. I work with safety checklists. So for me, I would say patient safety is using surgical safety checklists.
Patient safety to us means not just care and safety for the patient, but adequate resourcing and training for the anaesthetic team.
Patient safety is the fundamental in anaesthetic care because unsafe care is uncaring, inappropriate, unacceptable, and we call on the patients themselves to tell government and hospital administration that patient safety must be the #1 priority.
Great comments from some of our attendees there, and patient safety is of course a theme that will run throughout the rest of the meeting. Now, a big part of our job here at Euroanaesthesia TV is to shine a light on some of the great work done by anaesthesiologists from all over the world. Straight after this, we'll go to Canada's Schulich School of Medicine and Dentistry, Western University. But first, let's take a look at some of the highlights of our travels.
London is a great place to live and work because it's such a diverse place.
I arrived here in London, Ontario about 3 years ago, and I found it for me the ideal place to be.
We send a team with an anesthesiologist and a cardio technician to the patient to secure a stable condition in which the patient is able to be transported back home.
We provide regional anesthesia, neuroaxial regional anesthesia. We have also limbs blocks. So we are probably the leading hospital for regional anesthesia on a national level.
It is still very important to improve the care of our critically ill patients because today still too many patients die to their critical illness. We want to bring innovation and quality improvements to our patients to bring more patients back to life.
My name is Erin McCabe and I'm a fellow with the Department of Anaesthesia and Perioperative Medicine in London, Ontario in Canada.
My fellowship is in obstetric anesthesia.
I'm a clinical fellow in neuroanesthesia.
I'm doing the cardiac fellowship in anesthesia.
London is a great place to live and work because it's such a diverse place.
I arrived here in London, Ontario about 3 years ago, and I found it for me the ideal place to be.
There is so much opportunity for learning, a lot of opportunity for teaching, and I also get exposure to other types of anesthesia during the days when I'm not doing my specialty.
So in London we have 3 different hospital sites that all have their unique patient population. With that unique patient population we are offering 10 different fellowships across these 3 different sites. Currently we have 23 fellows across different subspecialties.
We have 3 TEE rounds per week, every Monday, Tuesday and Friday mornings.
TEE rounds is a transesophageal echocardiography. This is a special technique that is usually a subset of cardiac anaesthesia, where we can look at the heart during the surgery using a probe that goes down the patient's throat and into the stomach and looks at the heart from behind.
What is also exciting for many of the trainees is this center, the C-STAR Center.
C-STAR is the Canadian Surgical Technologies and Advanced Robotics Lab at London Health Sciences Centre in the Lindros Legacy Building. And it's a fully outfitted simulation facility with the mannequin-based high-fidelity capabilities, cadaveric and animal facilities, as well as many part-task training environments. We try to give them as many skills and abilities to deal with difficult crisis management situations in a simulation facility so that they're well prepared when they have to deal with those circumstances in clinical environments.
When somebody decides to have a fellowship training here with us at Western, we also offer the opportunity to do some research projects.
So my time is split about 4 days in clinical work and 1 day for research work. My research is concentrated on heated humidified high flow nasal cannula oxygen therapy, which is one of the new types of equipment that is used for oxygen therapy these days, mostly in the ICU, but now we are trying to translate it into a perioperative setting where it can be used more and more in surgeries like awake craniotomies in neurosurgery. And that is one of the main focus of our investigations here at London.
I was able to present 3 abstracts at the SOAP meeting after a sort of 1-year fellowship, something that I was quite proud of. And in addition to that, the Society of Obstetric Anesthesia and Perinatology this year awarded us with the Center of Excellence. And we're very, very proud of getting this recognition.
I like the community of a large fellowship group. We meet out of the hospital because we all come from different cultures. It's kind of an adventure, and for me the adventure was so positive that in the end I stayed.
Some of my favorite things to get are emails from previous trainees when they're out in practice saying, Dr. Cherry, I remember that time that we were in the simulator and we maybe did an emergency airway procedure. I just want to let you know I had to do that in real life in an emergency department and it went much better because I remember that experience in the simulator.
So as my fellowship is coming to an end, I'm so happy to say that the department has offered me a position as a full-time staff, and I'm so excited to start working here with this great group of people.
Anyone who hasn't been in this part of Ontario, I would certainly strongly suggest them to come and visit. The sunset is one of the most beautiful sights one would ever see. It's out of this world. Welcome to London, Ontario. We look forward to seeing you soon.
আপনাদের সঙ্গে আবার দেখা হবে.
Bienvenue à London, Ontario.
Ik hoop hier snel te kunnen ontmoeten.
Und wir freuen uns darauf, euch bald hier willkommen zu heißen.
Exciting work there from Canada. Now, research across the broad spectrum of anesthesiology is essential for saving and improving patient lives. To support this, the ESA has set up the Clinical Trials Network, and joining me now to discuss it are Professor Fuchsbuder and Professor Bora. What kind of studies does the Clinical Trials Network support and how?
The latest study published by the Clinical Trial Networks is the so-called Popular study. It was published by a first author called Eva Kiermeier, and this study focused on management of neuromuscular block across Europe. In this study, more than 20,000 patients were included, and unfortunately, less than 20% of these patients were appropriately managed with regard to neuromuscular block. We'll say appropriate monitoring of neuromuscular block and, if needed, reversal of neuromuscular block. The result was a little bit disappointing.
In the past, the clinical trial network supports a couple of trials dedicated to pediatric anesthesia because there's truly a lack of knowledge about the outcome of surgery throughout Europe because we simply do not know that on beforehand. And we also decided to support a couple of trials dealing with ventilation in the operating theatre. All of these topics are not easily fundable by a couple of other funding societies, so we feel the clinical need to answer this relevant question.
What from these studies will transfer into patient care?
The consequence of popular must be that we improve the application and the acceptance of neuromuscular monitoring, which is a key element of self-management, and we need as a society to come up with appropriate guidelines and implement these guidelines into clinical practice. This is one of the major lessons from this study.
I think in particular in the aging population we are now in the first step. That means we generate knowledge, and thereafter we have to develop strategies together with the research groups to figure out how can we take or how can we organize the optimal care for this patient population.
You'll be accepting submissions for a 2019 round of funding later this year. Are there any areas you'd particularly like to see explored?
As a society, our main interest is always patient safety and patient outcome, and our applications go exactly in this direction this year also.
How might political events in Europe affect study funding choices?
We are interested in supporting research groups throughout Europe in applying for, let's say, European Union Horizon 2020 funding projects. In other words, we are closely connected to the institutions in Brussels to find out what is the next idea of the European Union, how will they organize funding.
This European funding is a very important funding for our society, so this is one of the big issues currently.
Yes.
Professor Bura, I understand you'll be presenting your exciting Prodigy study to us as well later at the conference. Can you give us a teaser of that?
We were interested in finding out if the use of opioids, which are extremely prominent in the press a couple of months and years ago, in particular in the US, is really a big challenge in perioperative medicine. In other words, are there people which get harm from pain treatment after surgery? And what we did in Prodigy, we did a worldwide study which took place in Europe, the US and in Asia to figure out how big this problem is, and moreover we worked on a prediction score to find out which patients needs additional monitoring. And I will present together with the study team indeed here the results of this very exciting trial.
That was fascinating. Thank you so much for joining us. Now, with more on the latest research, we caught up with Professor Marcello Gama de Abro to talk about the Protective Ventilation Network, performing cutting-edge studies in mechanical ventilation strategies, including the CTN-funded PROBE study.
Anesthesiologists, they have been performing mechanical ventilation in the operating room, in the ICU, but we really don't know which are the settings that are most protective for the individual patients or for a group of patients. This is the reason why we grounded the PROVNet, Protective Ventilation Network. Our goal was to find associations first between mechanical ventilation and outcome in terms of pulmonary complications, for example. And based on those findings, go to interventional trials, to randomized controlled trials, where we test if a given setting has the possibility of influencing the outcome of those patients. We have a different range of studies from the PROVNet, observational studies, but also interventional. For example, we have the PROTHOR trial, an investigation of the effects of different levels of PEEP, a higher PEEP combined with recruitment maneuvers versus a lower PEEP without recruitment maneuvers during thoracic anesthesia, during one lung ventilation in patients submitted to lung surgery. Surgical obese patients, they are at even more increased risk for postoperative pulmonary complications. What PROBE is aiming to was to answer to this question: a higher level of PEEP versus a low level of PEEP. Which one will lead to less postoperative pulmonary complications? This trial was initiated about 4 years ago, and now the trial is finished. We have the results available and they will be shown during a lecture. I invite you to see for the first time, it's a premiere. So what are the results of the ProBeast trial?
Make sure to catch the exciting results from the ProBeast study later on in the meeting. Now, with more from Professor Guillermo de Abro and his team, let's go to the Technical University of Dresden, where, amongst other things, they're doing exciting work in state-of-the-art regional anesthesia techniques.
Herzlich willkommen in der Klinik für Anästhesiologie und Intensivmedizin. Welcome to the Department of Anesthesiology and Intensive Care at the University Hospital at the Technical University in Dresden. We are a team of around 150 anesthesiologists and 200 nurses and assistants. We perform 35,000 anesthetics per year and take care for more than 3,000 intensive and emergency patients. We have a special strength in cancer surgery, complex surgeries in abdominal, thoracic, and neuro and vascular surgery, as well as in pediatrics. We deliver also the acute pain service on a 24/7 basis.
Every surgical specialty has their own coordinator for anesthesiology, so they are highly specialized for what they are doing. We have the newest generation anesthesia devices. We have also the newest drugs so that we can provide the best standard of anesthesia care for all patients. We provide regional anesthesia, neuroaxial regional anesthesia. We have also limbs blocks. So we are probably the leading hospital for regional anesthesia here in the neighborhood, but also on a national level.
The ICU of the anesthesiologic department has 30 beds, and we treat about 2,200 patients in this ICU per year. The most important thing is to teach at the bedside in interdisciplinary rounds with our colleagues from the surgical departments, with the physicians and with the students. We offer consultations for the smaller hospitals here around in Dresden or in Eastern Saxonia. We can transfer patients from these hospitals to our unit with our own ITV mobile. We use, for example, ultrasound machines, sophisticated ventilators, modern and latest machines for renal replacement therapy or ECMO therapy.
We are recognized as regional ECMO center. That means we have a 24/7 hotline to get our opinion to optimize therapy or to request to transfer them to our center.
We perform both veno-venous and veno-arterial ECMO, both in the operating theater, for example, for vascular or thoracic surgery, or on the intensive care unit. We are also running an eCPR program for patients with cardiac arrest, but our main focus is veno-venous ECMO for patients with ARDS. We have an ECMO nurse and a specialized ECMO physician that are teaming up on a 24/7 basis. They are on call to deliver ECMO services in the hospital and outside of the hospital.
This is a special big trauma center. Severe injured patients, we receive about 350. Normally injured patients, there are about 10,000 a year. We have all specialties, so we have all kind of surgeons. And another important thing is that we train a lot to work together. The polytrauma algorithm is a tool that helps people from different specialties. They come together, they do the right things in the right way, and they can take decisions together. Time management is very important for the patient.
The great advantage of the University Center is the multidisciplinary approach to treat pain. We work together with neurologists, orthopedics, psychologists and psychotherapists.
We are providing care for any patients suffering from chronic pain, cancer pain, up to headache patients and patients suffering from any kind of musculoskeletal pain. The majority of our procedures is the examination of patients and treating patients with medication or physiotherapy or psychotherapy. Newest equipment is quantitative sensory testing and electroneurography for patients suffering from neuropathic pain.
The broad spectrum of duties in my department requires a special training of our physicians. We have a structured curriculum which consists of practical courses in the simulation center, for example in advanced life support, pediatric life support, and in addition decision making in the team and leadership in special situations.
We have basic research using cells, we have preclinical research using small animal experiments, large animal experiments, and we have also a very strong clinical research. Possibly the strongest research that we have is the respiratory research, and we test new forms of ventilation. Some of them we have created ourselves, we have patents on that, and today they are so developed that they are being used in patients already. We have questions that come from the OR or from the ICU. We go with those questions to the lab, to the bench, and then we come with the answers back to the patient, and we try to improve the patient care.
We have some new projects in the pipeline. For example, we just founded the Comprehensive Sepsis Center, and in this project we developed a clinical pathway for the acute and post-ICU care of those patients. We will work together with engineers and IT specialists to implement deep learning and wireless sensors for integrated advanced respiratory support. My personal aim is to continue the trustful collaboration in my team to provide best patient care, teaching and research.
Now, they're leaders in anesthesiology with a wealth of experience and insight into the state of the art of the field in 2019. We sat down with the President and President-elect of the ESA to discuss everything from big data to the second victim phenomenon. Thank you for joining me, Professor De Hurt, Professor Zakharovsky. So, Professor Zakharovsky, you've said that millions of lives can be saved globally if patient blood management is adopted universally. Why isn't it adopted universally?
Probably every fourth person on this planet is suffering from anemia. And we know if you're suffering from anemia, it has different grades, and you're undergoing elective surgery, the risk to die is increasing by 5 to 13 times. Half of these have a simple cause, it's iron deficiency. This can be cured easily, and then but it's not being respected worldwide, so people are still going for elective surgery, being anemic and having a bad outcome. And it's not only deaths, they have an increased risk for infections, 4 times increased risk for kidney failure, for stroke, and so on and so on. Knowing all these facts, and we're not doing anything about it, it's bad, and therefore we are here and talking about it.
Moving on to the second victim phenomenon, how big a problem is that with anesthesiologists?
Well, it's a big problem, and the big problem in that is that it's frequently underestimated and underreported. So people suffer in their own without support from their peers, and that's a main issue.
What is ESA doing about second victims?
ESA is trying to emphasize awareness around the problem, and what we are doing with our task force on sustainability and on professional development is provide kind of white paper that can be used at local, national, society levels to help their members to deal with the problem.
In terms of big data, how can that transform anesthesiology?
So what we need is to have the data coming out of the machines, breathing machines, monitoring, being collected in devices where all these data can be then increased to big data and then being analyzed and telling us then what we have to change in our practice. And this is just the beginning now of a completely new century, that we are changing from a paper-based documentation to For example, you're carrying at the moment an iPad, we're collecting data in an iPad. Even the patient identity can be photographed with a camera and the case is in. So that is a completely new development and we have to work on.
So, Professor de Hert, as outgoing president, what is your proudest accomplishment when you've been with the ESA?
I'm very proud on the attention that we were capable to give to the problem of gender equality, certainly within the society. We have an increasing number of female physicians going for positions, leading positions within the society. I'm also very proud on the fact that we turned the Congress into a more green Congress.
Professor Zakharovsky, how do you hope to bring your interest into the position of ESA president?
I would like to introduce more into, on the European level, the introduction of patient blood management. The second thing is I obviously would like to get in every country hospitals within Europe using more electronic documentation systems so that we can pool the data. Well, my third goal is to rediscuss and renew the whole issue about intensive care medicine. And this is because we have a new generation of young doctors and they are not prepared to work for the next 30 or 40 years in shifts. This is what you have to do in the intensive care. So we need to find solutions how we are able to care for patients who are in need of intensive care, but on the other side, make it attractive working in the field. And I personally believe it's only possible when you have a department with a lot of anaesthetists and they're rotating.
Well, it's very inspiring. Thank you for joining us, professors, and good luck with everything.
Thank you.
Thank you.
Really exciting stuff there from the ESA presidents, and we look forward to seeing the role new research and ESA initiatives have in the field. Now, that's it for the show today, but as the conference gets started tomorrow, we'll have plenty more to show you, including an interview with Macintosh lecturer Professor Paolo Pelosi and a visit to the SimSpace to check out the latest simulation techniques. Until then, keep watching, online, in your hotel, and around the Vienna Messe. We'll see you tomorrow.